With venipuncture insertion, bevel should always be up. Insert at about a 15 to 30 degree angle depending on the depth of the vessel. The deeper the vein, the greater the angle, but should not exceed that 30 degrees. Greater angles risk hurting the patient. Dorsal hand collection, the proper angle is about 10%. The angle is going to be a lot shallower. And we want to use a quick, smooth movement to enter the skin. A picture of the correct arm positioning. This is going to show a hematoma to the right there and cellulitis to the left. So the cellulitis is that red area, and then that very dark burrs there. Veins and heel stick. So there's a picture of our veins that we use in that anacubical area. So that cephalic vein is there, the accessory cephalic. The median cubital vein, that is the one we primarily use, and then that basilic vein is the one we try not to use if we don't have to. That runs along very close to the brachial artery and some nerves, and so we try not to use that area. The other picture there shows some normal veins and then shows you those curly veins that are those varicose veins. And then the areas of the heel where we would perform heel sticks on the infants. Just a few more pictures for you to see. Venipuncture in order of the draw. Blood culture bottles or the yellow tube stoppers are always going to be done first. The anaerobic should be used first if we're using the syringe method. If we're using a butterfly, we should do the aerobic first. Next would come the light blue, and then our serum tubes, which those include our red, our gold, our speckled red and gray, and then red and black. Our rapid serum tubes would be next then, would be the ones with an orange stopper, followed by green, lavender or purple, pink, and then gray. Some commonly used anticoagulants would be sodium citrate, light blue used for clotting tests. So those are in those light blue tubes. Our EDTA, those we see in our lavender or pink tubes, used for mostly hematology tests. Heparin, we see those in our green tubes used for most chemistry tests. And then potassium oxalate or sodium fluoride in our gray tubes used for testing sugar. Patient safety is number one. We need to make sure we maintain patient safety throughout. Observe our surroundings, the patient status, visually look at the patient's arms. Most patients are going to tolerate well, but some can act extreme. Make sure we're asking questions, explaining the procedure to the patient as well. Some complications that we may see, we might not be able to see or feel the vein. We might miss, pull the needle back slightly. Do not blindly move the needle around. That can cause nerve damage and things. We can also see, or we can also cause hematomas, phlebitis, so that inflammation in the vein, thrombosis, petechiae, hemoconcentration, collection errors, syncope in the patient, so the patient might pass out. Removal process, we want to remove the needle at the same angle as we inserted it. Again, we want that swift, smooth motion, and as soon as that needle comes out of the patient's arm, we want to engage that safety immediately, and then place that needle into the sharps container. Inverting our evacuated tubes, we want to do that immediately after filling. We want to invert those tubes. We don't want to shake them. We just want to do, a nice back and forth invert a few times. The inversion is going to depend on the color of the tube that we're drawing. So if we are drawing light yellow or green, lavender, or gray tubes, we're going to do about 8 to 10 inversions. If we are drawing light blue, we only need 3 or 4, and then our serum separators, we would do 5 inversions. Capillary punctures are performed by doing either a finger stick or a heel stick. We perform these tests if it just requires a small amount of blood. The patient might not have accessible veins, so we may do the capillary puncture if capillary blood is needed. Patients who are at risk for iatrogenic anemia, so that anemia is caused by multiple venipunctures. So we see those in patients who are in critical condition and things like that because they're having multiple blood draws, and so they can end up with the iatrogenic anemia. Common for many POC type blood tests, so checking like cholesterol, glucose, or hematocrits. So for capillary order of draw, a little bit different. So we're going to draw blood gases first if we need them. We would draw purple, lavender, pink, or pearl, green, and then any other additive specimens, and then serum red or gold. Labeling, again, is very, very important. We must label in front of the patient so we don't take specimens out and then mix them up with another patient's and label wrong. We need to have the patient's full name, date of birth, the date and the time, and then their medical record. And then usually we're going to add the initials and the time as well. Post-procedure care, know the status of our patient again. Make sure adequate pressure has been placed on the collection site to stop bleeding. And before we place that bandage, we really need to make sure that that bleeding stopped. A lot of the times I see phlebotomists, they put pressure on there, they don't look at it again, they just place some tape over it, and then a few minutes later the patient's like, and they're bleeding all over. So some patients' veins take a little bit longer to close back up, and so before we really place that tape or that bandage, we want to lift that cotton ball up, look and make sure that that vein has stopped bleeding. Promote hemostasis and help prevent bruising, so again, it's important to apply that pressure bandage. Observe for indication of any kind of complications. Look, listen, and those things. We want to make sure that they don't look dizzy or diaphoretic, sweating, that they don't have any of those complaints before we let them stand up and walk out.